Good morning. Welcome to this presentation. I will serve as your host, Denise Maxwell, and the research symposium session entitled Innovation, the Panacea to Overcome Competition in Healthcare is being presented by Dr. Michael Bimpeh. We are excited that you've chosen to join us this morning to hear Michael Bimpeh's presentation. Your mics will be muted during this session. However, the chat window will be open during the session, so please feel free to participate or ask questions. Michael will address chat questions during the last 5 minutes of the presentation. I'd like to welcome Michael Bimpeh. It's nice to have you here. A little bit of background on Michael. He has lived in New York City since 2010. He holds the following degrees: a PhD in organizational development and leadership, which he earned in the United States, a master's of business administration from Sweden, a master's of science in built environment from Sweden, and a bachelor of education in social studies from Ghana. Currently, Michael is an adjunct instructor at a college in New York City. Welcome, Michael. We're excited to learn from you and participate in your presentation.
Thank you, Dr. Dennis. The title of the research is Innovation, the Panacea to Overcome Innovation in Healthcare. So healthcare is very complex because the departments are established on specific service lines. For example, GYN, vascular, cardiac, spine, ENT, etc. And besides that, it is an institution that is well regulated by federal, state, and local organizations. So there is no room or tolerance for errors because it's about life. So errors are not permitted, even in the smallest way. And more than this, there are a lot of patients from various ethnic backgrounds, ages, and so on. And also, healthcare has a lot of stakeholders, from the owners, patients, physicians, community, etc. So all this affect innovation, and then also impacts on service performance in healthcare. And research has shown, empirical research has shown that about 30%, 30 to 90% of all innovation that have been tried in healthcare failed, while depending on the criteria in a way that used to judge innovation. But that is the research, 30% to 90%. So if 30% to 90% innovation fail, this is very alarming. But in spite of this convoluted situation, innovation is not a bargain, because the environment or the competitive environment is very turbulent. They are competing to survive. And so this creates a survival dilemma for healthcare organizations. And there is an interesting trend in healthcare in recent times: rising cost, aging population because of advancement in healthcare provision, advancement in digital health, more data usage, mobile health, especially in this era of the pandemic. We have seen or watched on the TV that a lot of people are moving towards, from going to the hospital in person towards mobile health. And there is also superior technological advancements. A surgeon can be in far away, for example, Japan or England, and conduct the surgery in the US and all these things. And strategic measures in New York. There are a lot of notable measures and acquisitions. And also there's also patient engagement in recent times. We have seen that some health organizations involve patients in their meetings once every month. In my studies, I realized all that. There's also increasing needs and demands for patients. Patients are becoming more and more free and vocal, and they want the best for the money they pay. Now, the specific problem is that healthcare consumers continue to have increasing service expectations and variable patient needs. Patients continue to need the best. They always require, in fact, they want the services to be the best for them. But then the question is there a corresponding innovation to make them happy? A case in point, New York City, where I live and where the study was conducted, 18 hospitals have closed between 2003 and 2016 because of acute financial crisis caused by drastic reduction in patient census. And to learn that in just a period of 13 years, only one city, 18 hospitals closed is very alarming. And so this alarming rate of closures create a problem for the study. Now, it's very interesting that when 18 hospitals closed within this short time, 13 years in one city, at the same time, some hospitals were performing very great, very great. So the question is, why as many as 18 closed and those who were about to close had to merge? But then at the same time, others performing incredibly well. So this means that there is a kind of unknown underpinning service innovation theory that likely stimulates innovation in the high performing organizations, healthcare organizations. So my goal was to unravel the unknown service innovation theory that drives innovation in the successful healthcare organizations. So the purpose was that to understand service innovation strategies adopted by an innovation healthcare organization so that I could construct a theory that was grounded in the data to explain best practices in designing and implementing service innovation. So the whole study was conducted within the framework of grounded theory. Obviously, if you want to generate or develop a theory, grounded theory is the best. So I use that. And there are 3 configurations of that. And I use the latest called the constructivist, developed by Chalmers, because that allowed for a lot of, you have a lot of flexibilities, in that. So I use that. And based on the situation, I developed a Richards equation, what theory of innovation grounded in the data can be derived from studying service innovation strategies that are linked to high performance in healthcare organizations. So I use clearly qualitative method, and then I use the constructivist, and the coding stages were 3: initial coding phase, focus coding phase, and the theoretical coding phase. And I use a researcher-prepared, semi-structured, open-ended interview protocol. And the population, very key in this study, was a high-performing healthcare organization in New York City. The name obviously cannot be disclosed. And what criteria or metric did I use? I chose the HCAHPS, something we call Hospital Consumer Assessment of Healthcare Providers. This is an assessment done by patients. So it's an assessment through the lens of the recipients of the healthcare services who are the patients. So they measure, and it is standardized and used across the United States. Federal organizations use it to make their decisions and state. So the target population was internal medicine. Why did I choose internal medicine? Because everyone going to the hospital first goes to that unless you are referred to say specialist. But that's the first point. So they have a lot of interaction with people. And I use purposeful sampling because it was qualitative. I wanted to talk to people who have been there for so many years, have witnessed the various changes, innovation. 16 participants in all, 2 management and 14 employees. 4 were males, 12 were females. Gender balance was not required in this situation because I wanted, the tenure, long tenure, people who have stayed there for a very long time, who have witnessed. So if I wanted to ensure a gender balance, meaning I would have been able to, skip some of the people who spent several years in their places. So the manager, those in the management position, from the manager, the supervisor, then we have other like RNs, LPNs, and PSRs, check-in, check-out, and all. So 14 out of the 16, served in the hospital between 10 and 30 years. Only 2 of them were below 10 years. Recruitment was assisted by the director because I didn't know when somebody was employed. There was a one-on-one interview, and data saturation was attained by 16 employees. And these are the coding phases in the constructivist. Initial coding phase, focus, and then the theoretical. Now, the results suggested that 6 service innovation strategies linked to increased performance in healthcare. These are consolidating related services. And let me explain this briefly. In the past, they told me that the services were scattered. For example, a patient comes in, to see the PCP. Then the PCP will want the patient to go and see, let's say, dietitian. So that patient will have to leave the building and go to another location, and all this will, generate a lot of, stress. So they decided to merge everything, social worker, dietitian, and all. So when the patient was at the hospital one time, the patient, if there is the need to see a dietitian, the patient can right there, that very day, see a dietitian or social worker. Service accessibility. They have satellite locations, meaning that the hospital was chasing patients, not patients chasing the hospital, and patients like that. Wait time reduction. They use something they call patient navigation. Oh, it was very interesting how they do that. Once you arrive, you are already checking halfway, even before you see the register on the desk. They engage patients in meetings once every month, and context diversity planning. New York is very diverse and very cosmopolitan. I don't have any data to prove it, but I believe that it is the most diverse city in the world. So if you are treating or you are rendering service to diverse people across the world, it follows logically that your staff must also be diverse. It was very interesting to realize that they have doctors, nurses, and from almost every country, almost, at least continents. And so, for example, well, my origin from Ghana, if I go to the hospital and I see a Ghanaian doctor, physician, or nurse, I'll feel more, comfortable in going to that person. So that was a strategy they use, and patients like that. Computer technology, they integrate a lot of computer. So with this 6, I came up with this model called internal service medicine service innovation model. And when you consolidate related services, it reduces time. When you use a lot of computer technology, you reduce time. And service accessibility, they have satellite location and all that reduce even wait time. And all this, I've realized that contribute. And that was the reason that healthcare was emerging successfully and is still emerging in the city of New York. Now, implications for the research and for research and practice. Implications to research. The constructed theory, the IMSIM, represents evidence-based knowledge to drive service innovation in healthcare organizations. The IMSIM will serve as a research framework to enhance performance in healthcare organizations. So since this is about healthcare, it is highly applicable to healthcare organizations. Service innovation is still evolving in healthcare. So this, gives evidence or support to this study because it's on service innovation. Healthcare innovations are predominantly service innovations, and my study is also on service innovation, so contributes to that. Let's come to practice. Healthcare management can use it to develop, and practice can develop interventions to stimulate service innovation in their healthcare institutions. And practitioners outside healthcare, for example, banking institutions, insurance, we saw the wait time reduction in the model. When you go to the bank, you don't want to spend the whole day, or you go to your insurance firm, you don't want to go. So that's also applicable, to them. Let's see implications for theory. Now, this study was, done within the framework of diffusion of innovation theory. And this theory, diffusion of innovation theory, DOIT, has 4 components: the actual innovation, communication channels for the innovation, the social system, and time speed. And when I compare this, the area of convergence, so the IMSIM, which is my theory that I developed from my study, with this, there are at least 2 clear areas of convergence, and even 3 because of the time speed. So the actual innovation pertains to both the IMSIM and then the DOIT. The context diversity planning, we just saw that here, that there is context diversity planning over here, and that is also over here, the social system relates. So this shows that the 2 theories converge, at least to give some sort of evidence that is very critical. Let's come to limitations of the study. Transferability of the model to other departments will not be supported empirically and scientifically, because this was conducted specifically in the internal medicine department. So if you want to apply this in cardiology, GYN, spine, ENT, or vascular, may not hold. Existing theory was discussed, which is not the tradition, granite theory. Granite theory is not the best to start with. Sorry. Now, let's go to the recommendations for future research. Now, future researchers may use a case study approach to just get general factors that drive service innovation. I was interested in developing a theory. Future researchers may use mixed design method where quantitative approach will integrate it into the quantitative towards offering a validity and reliability to support or to disprove the qualitative findings, which of course qualitative is most often subjective in nature. Future researchers should include patients. In this study, I did not include patients, I only include the service providers. But realistically, the patients are the recipients of the services. So it makes real sense that any future study should involve patients to have their side of the story. Then also future researchers could replicate the study in a health organization different from New York, because this was done in New York. New York has a different geographical system, and it could be replicated in another area. And these are the references to the in-text citations, goes on the next slide, and I have my brief information over here. Thank you for your listening.
Michael, thank you for your presentation, very informative. Peggy Sundstrom has a question, and you did go back a little bit, but I wonder if you have more details and information you'd like to share, and if you'd like to go back into your slides, that's fine. But just asking, can you explain more about the context diversity planning that you referenced in your study?
Oh yeah, that's very relevant. If you are serving a population that is diverse, I want to go back. Yes, yeah, context diversity planning. If you are serving a community, a population that is very diverse, it is strategically wise to have the people that are providing the service also to be diverse. Human beings are visceral. They get, pushed towards a person that they believe they share common features. So, for example, I'm from Ghana, my origin. If I should go to a hospital and I see a Ghanaian doctor, someone also from Ghana, there is a high possibility that I would like to move towards that. That's what I mean by human beings are visceral humans, or creatures. We want to move towards a place that we share common identities. So the hospital, strategical, has a lot of physicians scattered across the world. Not they live outside, they live in the US in the hospital, but their origin is from various places, and the nurses as well. That's exactly what I mean by context diversity. That means that the context of New York was factored into their recruitment of hiring physicians and nurses. That's exactly what I mean.
One of the things that you shared with me when you were preparing your presentation was that at first people only wanted to conduct the survey or be interviewed by you on the phone, but you moved to face-to-face. Could you talk a little bit about the benefit of that and the experience that you had in conducting the interviews with the employees?
Yeah, thank you. There was a challenge when I wanted to have a place for my study. I put in an application. First, I worked there, and they didn't allow me to see anyone. So finally, a nurse told me that, well, she will talk to the boss. So along the line, to cut long matter short, I know we are operating within a very short time. That nurse sent me email, and I responded. So another person who was in charge of research in the organization called me, and he wanted to hear my story, what I wanted. But in fact, as all of you can tell, I wasn't born in America, so I don't speak the American accent. So it was a challenge, and I know that for you to be very smart, physical, face-to-face has power than being talking on phone when you have accent. So because of my accent, I wasn't enthused about the phone interview. So I told the person, well, I live in New York, very polite. If you don't mind, I can just come and see you in person. Is that fine with you instead of on phone? Then he said, okay, come in. So when I went, he confessed to me that if the interview had been conducted on phone, he would never have allowed me. And that for the past 10 years, they never allowed anybody from outside to come to conduct. So that was, something that I did that really helped me. If you have accent, the best thing is that try to ensure more contact with people that will have some influence. You can, communicate more so that you may not be pushed away by your accent.
Thanks, Michael. And Susan asked if you'd go back to your contact information slide. I think you've got some people who want to follow up with you.
Yes, right on the screen, yeah.
we still have a little bit more time, I
That's
believe.
fine.
So Peggy is asking, what kind of response did you get from the individuals involved in the study as to their willingness of practicing innovation?
Oh, in fact, they were very enthused and they were very supportive. Uh, some people were there like 33 years, one woman. Oh, it was very coincidental. The very day I was interviewing her, that was the day she was, sorry, the following day she was going away. And she said that they have realized that that was helping the organization a lot and they were very supportive to the management. So I see that when management involve workers, they are happy. When workers feel that they are sidelined or marginalized, maligned, that's when there's tension. They try to kick against it. So from what I learned, oh, it was a great, and they were very supportive. They gave me one full room, closed door, interview one-on-one. It was, yeah, recorded. And the workers were happy that they were really involved all the time.
Did you sense any resistance to the effort required to implement the innovations?
Not at all. One thing I learned that I would advise every healthcare to apply that. See, when you involve workers, human beings by nature, they want to feel that they are respected and their inputs are valued. So they told me that they were always consulted. The top leadership never imposed things on them. They were always involved. And because of that, they felt that, well, they were valued. So that's one thing I realized from the study. So when you want to make sure that there is implementation of your innovation policies, you must, I use the word must, involve the people, because they are the real people going to implement it. If you don't involve them, they'll frustrate the whole system and make sure that it fails, just like the 30 to 90% that, that fail, as I said already.
One of the questions I have for you, and I think all of our research is always restricted to the population that we can have access to conduct the study. So I'm wondering if you have a hypothesis as to what the outcome of your study might indicate if your population studied were patients that were serviced by the same hospital.
Well, it might change, but I don't think the change will be drastic or significant. Because over here I have a patient engagement. Yes, patient engagement. So most of the innovations that they practiced or implemented came from suggestions from patients. So if I had included patients, I believe that, well, most of the things, I'll get will be the same thing that, I found, over here. But definitely some added, things would have been added anyway, some more information would have been added anyway, for sure.
So I think we have time for one more, and Marjorie asks, and she's asking you to do a comparison maybe between services in Ghana and where you currently live in New York. So her question is, of the 6 innovative strategies, which strategy seemed most impactful to improvements in service delivery? And she's asking you to compare it if this model were implemented in Ghana versus New York.
In New York, I would say the context diversity is very, very critical. And this one, the two. Well, I mean, you want me to just choose one, but then please, I'll choose 2, the context diversity, because they told me, 2 of the participants told me very clearly that when people come, for example, they speak Spanish, they only want to meet Spanish doctors, no one. But in my country, Ghana, if I have to compare, is the wait time, because we belong, one culture, we just belong to one race or ethnicity. So we have everything in common. So the wait time in my country, you can spend about 5 hours in hospital, 6 hours in my country, Ghana. So the wait time is very, very critical. That's the reason private health organizations in Ghana are now having superiority over the government hospitals, because they are able to ensure that the time spent is reduced. So in my country, I would say the wait time. In the US, I would say consolidating, and then the diversity, the content diversity planning, very key in New York.
Well, Michael, I'd like to point out you've got several comments in there thanking you for a well-researched presentation, and people really appreciated what you shared. So thank you so much for your presentation, and also for all the participants for joining us in this session today. You saw Michael's contact information, if you want to put that up again really quickly for anyone who might want that.
Oh, sorry.
And so the recordings of the presentation will be available in June to be accessed through the conference website. So thank you for participating. I hope you take advantage of some of the other sessions today and tomorrow. Thanks, Michael, for everything.
Thank you very much, and thank you, everybody. I appreciate it.
Thank you. Good presentation.
Thank you.